Hello, students. Uh, Today, let's talk about pediatric pharmacology. I'm Dr. Sindhu from Department of Pharmacology, Kaktiya Medical College. So, regarding pediatric pharmacology, today we will be learning what what is pediatric pharmacology, and then how the pharmacokinetics, pharmacodynamics are getting affected in pediatric population when compared to adults, and how do you prescribe, what are the principles of prescribing drugs in pediatric population, and what are the dosage forms, how the dose is calculated, and everything we will be seeing today. So continuing, so these are the contents what I'll be dealing: age, introduction, age classification, pharmacokinetic changes, pharmacodynamic changes, pediatric dosage forms, adherence, and calculation of pediatric drug dosage. So, basically, the drug therapy in children is different from that of adults because the drug dose is usually based on body weight and surface area in children. This is because newborn and children have physiological differences from adult in terms of pharmacokinetic properties. The physiological processes that influence pharmacokinetic variables in infants are significantly altered in first year of life, especially during the first few months. Therefore, special attention must be paid while administering drugs in this age group. Like we have to take special care while administering the drugs in children below first year, and especially during their first month of the birth, early few months. And then the pharmacodynamic differences are probably small and have been less explored except for these specific target tissue that mature at birth or immediately after birth. And then coming to the age classification has a significant role when evaluating anything about the pediatric population. And before this neonatal stage, we have preterm child, and we should also know about the preterm child and the term child. Preterm child is nothing but the child who is born before 37 weeks of gestation, and then the term child is 37 weeks or above. After 37 weeks, the child which is born after 37 weeks is called as the term child or termless child. Then coming to the other differentiations, like other age classification, when do we call a baby as a neonate? It is when the baby is born, like the 0 to 28 days, we call baby as a neonate. Even in neonate also we have two subdivisions, that is early neonate and late neonate. Early neonate is when the child is from 0 to 7 days. The first week, when the child is born, that first week we call as early neonate. After that, from 8th day to 28th day, we call them as late neonate. Okay, so neonate means 0 to 28 days, early neonate means up to 7 days, late neonate we call them from 8 to 28 days. Then next we call who is infant. Infant means from 29th day to 1 year, we call them as infants. From 1 to 2 years, they are toddlers. 2 to 5 years, we call them as preschool age children. Then 6 to 12 years, school age children. 13 to 15 years, early adolescents. 15 to 18 years, late adolescents. These are the classification of children. Okay, like after 18 years, that is adult. So we have to remember this. Next, coming to the pharmacokinetic parameters which are affecting drug therapy in children. Basically, there are different changes regarding the pharmacokinetics. So, mostly these changes are due to the normal physiology of the child, right? So, the change in physiology in first couple of years influences the pharmacokinetic properties in pediatric population. What are the pharmacokinetic properties? That is drug absorption, drug distribution, drug metabolism, and drug excretion. These are the pharmacokinetics, right? So let's see how each of these is getting affected and what are the factors that are getting affected in each of them. So coming to the drug absorption, we have different subtypes. Like in drug absorption, oral, we have oral absorption, then parenteral. If we are giving drug parenterally, then we are giving the drug per rectal administration also. How will that affect the absorption? And how does the, if you are giving a drug topically in children, how that skin absorption differs topically? So we have, let's see. Coming to oral absorption, this gastrointestinal absorption of drug in newborn, neonates, infants are different due to variations in gastric pH, gastric emptying time, intestinal motility, and gastric enzymes. So obviously, the gastric pH or gastric emptying time is different from adult and in children. Even in children also, the emptying time is different in first 6 months, and after 6 months also that is different. So let's see how differently they are there. So gastric emptying time is significantly slower in neonates and infant until first 6 months of the age. This may be partially responsible for delayed absorption of orally administered drugs like sulfonamides. Okay, we just have to remember that as an example of gastric emptying time, which can delay the absorption. Drug is sulfonamides. It also depends on both gestational age and disease states. Like if the baby is having any disease, like any disease related to gastrointestinal, then that may delay the gastric emptying time, and that may delay the absorption of the drug. Next, coming to gastric pH, first 24 to 48 hours after birth, basically the gastric pH is low in children, and otherwise the neonates have the near neutral pH in their first 1 to 2 weeks of life. As the gastric acid production begins, the gastric pH slowly reduces until 2 years of age. Like from 2 years of age, the acid pH will be equal to that of the adult pH. So till 2 years of age, like when the child is born, first 48 hours, like 24 to 48 hours, the gastric pH is basically low. And once the neonate is like after that 48 hours, then there will be neutral pH of the gastric pH of the neonate will be neutral till 1 to 2 weeks of life. And from that 1 to 2 weeks of life, this acid production begins, and slowly it will be getting reduced till 2 years of age until the adult levels are reached. What are the adult pH? It is pH is 1 to 3 in adult life. So from 2 years, the pH will be equal to that of the adults. In this, we have weakly acidic drugs like phenytoin, phenobarbital, and acetaminophen. These are best absorbed in their non-ionized forms. Okay. And in neonate or infant alkaline gastric environment, these drugs generally ionized. Thereby, they decrease absorption, and subsequently, therapeutic effects of these drugs are also affected. Okay. In contrast, for the weakly acidic drugs, we have weakly basic drugs like ampicillin, that is less ionized and better absorbed. Okay. So weakly acidic drugs, they are best absorbed in non-ionized form, and generally when they get ionized, the absorption of those drugs is decreased. But whereas if we are taking weakly basic drugs, then they are less ionized and they are better absorbed, contrast to the acid and basic drugs. And next, coming to the gastric enzymes. In gastric enzymes, what we have, basically in neonate, the gastric enzymes are reduced. Like neonate has reduced levels of gastric enzymes, pancreatic enzymes, and the biliary excretions. The presence of these enzymes may be required for solubilization, protonation, or deprotonation of absorption of certain drugs or drug molecules. There are many other issues of oral dosing in children, like spillage during administration, and few children that does not swallow medicine. Like if you take the older children, they tend to take the drug into the mouth, but they does not swallow, or they spit it out once when the parent is not watching. So there may be like different issues, and there are chances of vomiting, and test mask is essential because if there is any problem with any drug dosage, and the amount of redosing, how much we are giving after vomiting. Like if a child is having vomitings and you give them ondansetron, even what happens, sometimes the child vomits that ondansetron also. So again you have to check how much the child has vomited, and you have to keep giving the redosing. That is how it depends. And next we have intestinal motility. Lowered peristalsis in neonates. Intestinal motility is lowered in neonates and infants, which leads to the lower peristalsis leads to the reduced intestinal motility, and it slows down the medication transit. So the slower the transit, the absorption is much increased. The reduced gastric emptying along with the slow peristalsis increases the absorption of some drugs like penicillin. The motility pattern may vary in pediatric age groups and also for individual newborns. Motility is also affected by gestational age and maturity. This may affect the rate and extent of absorption, that is, Tmax and bioavailability of the drug is affected based on motility, gestational age based on motility. The lowered intestinal surface area of neonates and infants is also responsible for less absorption. So it affects the Cmax also. Cmax, Tmax, and AUC of a drug. We just have to remember is the lowered peristalsis will slow down the transit of the drug, which increases the absorption, and reduce gastric emptying time along with the slow peristalsis that increases the absorption. Okay. In neonates and children, as the what we say, as the intestinal surface is low, the drug is also less absorbed. And coming to the skin absorption, in skin absorption, the infants are at higher risk of toxicity via skin, because the skin is the larger surface area due to large surface area to volume ratio, and they also absorb more drug across the skin due to their thinner stratum corneum. This explains why infants have increased risk of methemoglobin with topical anesthetics. These are few physiological changes in the pediatric population. So what are the physiological factors we are taking here? Gastric pH, gastric emptying, intestinal surface area, intestinal transit time, pancreatic and biliary functions, bacterial flora, and how it is getting affected in a newborn, in a neonate, and in infant. So gastric pH, basically it is neutral or less in newborn, less than 5 in neonate. Infant, like from 1 month to 2 years, it becomes the adult, like how much we thought it would be, pH would be 1 to 3. And gastric emptying is basically reduced in newborn and neonate. It is more in infants, like when compared to the newborn and neonate, it is basically increased the gastric emptying time. And the intestinal surface is reduced in newborn and neonate. It becomes normal like adult after 1 month to 2 years of age. And the intestinal transit time is also decreased in newborn and neonate. It is increased in infants. Pancreatic and biliary functions are immature in newborn, like very much immature in newborn, just immature in neonate. And once the infancy stages occur, then they function like a nor adult. Bacterial flora is also very much immature in newborn, immature in neonate, and it attains adult in infancy. What are the other pharmacokinetic outcomes? Like rate and extension of absorption is variable in a newborn and neonate. It is almost similar or more in infants, like compared to adult. Gastrointestinal first pass effect is very much reduced in newborn. It is slightly reduced in neonate. and it is almost approaching the adult in infant stage. So these are the few physiological changes in the pediatric population. After that, let's come to how a drug is affected when parenteral administration is given. In parenteral administration, the rectal route is a very good alternative to oral route in pediatric age groups. Like basically, this parenteral route is preferred when the child is restless, or when the child is in unconscious state, or child is vomiting the drugs immediately after giving and all. So the rectal route may be good alternative to the oral route in pediatric age groups. The advantage is these dosage forms doesn't need to be swallowed, so they are devoid of taste masking. So rectal forms can be administered in restless child, unconscious child, or a vomiting child, a child who is vomiting, and in emergency also, per rectal route can be opted. Diazepam suppository are available for febrile convulsions. Sorry. Coming to parental preparations, in parental preparations, basically, the preferred route is intramuscular route. But though the absorption of the medication from the muscle tissue into the systemic circulation can be erratic, it depends on the drug's physiochemical factors and also the patient specific factors. Here, IM injections are generally well tolerated, but there is a risk of potential injury to the injected muscle or any other proximal nerves if the injection is not correctly administered. The best muscle to use for infants and small children is vastus lateralis muscle in the thigh. How the oral drug absorption of various drugs in neonates is compared with the older children and adults, let's see. Acetaminophen oral drug administration, oral absorption is decreased when compared to other old children and adults, whereas ampicillin and penicillin G absorption is increased when compared to older children and adults. And whereas diazepam, digoxin, and sulfonamides, their absorption is normal. I mean, just like adults, the absorption is similar to that of adults. And phenobarbital and phenytoin absorption is also decreased in neonates when compared to the older children and adults. After that, coming to drug distribution. The general factors involved in drug distribution are different in neonates and infants when compared to adults. These factors include like plasma protein binding and water or fat partitioning, etc., changing through the first few years of the life. The changes which occur are through membrane permeability. Membrane permeability means like blood-brain barrier, it remains immature at birth. So drugs can access the blood-brain barrier. They can pass easily, and they can cause toxicity. So the drugs can gain the access to central nervous system easily and may cause toxicity. Like for an example, in neonates, as there is a greater permeability in blood-brain barrier, it allows amphotericin. If you're giving amphotericin B, it passes and it achieves the higher concentrations in the brain than that of children or adults. For this immature blood-brain barrier, infants and children are more prone to develop kernicterus. Next, coming to plasma protein binding. At birth, human serum albumin concentrations are 75 to 80% of adult value, and alpha 1 acid glycoprotein is initially half the adult concentration. The plasma protein binding levels gradually increase with age. Concentration of plasma protein and their affinity towards the drugs both are low in first year of life. For instance, newborns exhibit lowered protein binding of drugs like penicillin and phenytoin. This results in higher distribution and lower peak concentrations of protein-bound drugs such as cefazolin. Basically, the protein binding capacity is lowered in drugs like penicillin and phenytoin whereas the higher distribution and low peak concentration protein-bound drugs are cefazolin. Next, coming to the body water, how this body water is getting affected. In neonates and early infancy, the total body water is high. Basically, that is 80 to 90% of the total body weight. And they have the low fat content. The low fat content would be 10 to 15% of the total body weight. The amount of total body water decreases gradually to adult value is 55 to 60%. The extracellular water content is also high in neonates when compared to the adult value of 20%. So the 45% of body weight and even higher it is seen in low birth weight neonates. We have to remember that. Due to these changes, water soluble drugs are are relatively higher volume, have relatively higher volume of distribution than in adulthood. Like for an example, gentamicin, linezolid, vancomycin. On other hand, fat soluble drugs apparent volume of distribution is similar or lower than adults. Example, diazepam. Fat soluble drugs like diazepam, their apparent volume of distribution is similar or lower than adults, whereas the water soluble drugs, the apparent volume of distribution is high when compared to adulthood. Body fat content. Next, we have the dosing information for obese children is limited and has been identified as area of research. Okay, we just have to remember that obese children, what happens generally, the dose is calculated based on ideal body weight. Okay, so what happens when we are prescribing for obese children? Sometimes the dose may become overdose when compared to that of adult dose. So still the information is in process and it is in research. Okay, so the obese children can be dosed using ideal body weight and the dose adjusted based on clinical effects. They are at higher risk of toxicity from drugs such as paracetamol that do not distribute into fat if actual body weight is used to calculate the dose. Coming to the drug metabolism, the metabolism of drugs is most complex between adults and children. So what is a common enzyme? That is cytochrome P450 enzymes are active in the fetus. Enzyme activity begins to increase during the later stages of pregnancy, and different rates of individual enzyme development seen in infants who are born preterm. The pattern of active enzyme changes over the first few months of the life to reach, or they even may exceed adult levels at around 2 years of age. Let's see what are the first phase metabolisms in children and how what are the examples of each enzyme. Or okay, so CYP1A, basically the drugs are theophylline and paracetamol. They are lower than that of adults until 1 to 2 years of age. Whereas cytochrome P2A6, we have valproic acid, halothane, tramadol, imipramine, and propanol. They are lower than that of in adults till 6 to 13 years of age. Whereas CYP2C9, they are lower than adult until 1 to 2 years of age. Examples are diclofenac, ibuprofen, phenytoin, paracetamol, and sulfonamides. CYP2C19, in lower than in adults until 10 years of age. Example, we have diazepam, lansoprazole, omeprazole, phenytoin, phenobarbital, imipramine, and warfarin. CYP2D6, until 12 years of age, we have promethazine, haloperidol, imipramine, metoclopramide, codeine, tramadol, and beta blockers. Next, we have CYP2E1. It is lower than that in adults until 2 years. Examples, we have halothane, paracetamol, caffeine, ethosuximide. CYP3A4, it is lowered until 2 years of age. carbamazepine, itraconazole, ketoconazole, phenytoin, zidovudin, erythromycin, sulfonamide, ethosuximide. Next, we have CYP3A5, similar to that of adults, codeine, diazepam, chlorpheniramine. CYP3A7, basically it is higher than adults in until 3 to 6 months of age. Uh, we have examples like ritonavir, nifedipine, statins, erythromycin, and midazolamide. MAO-A oxidative enzymes, they are increased until 2 years. Examples: serotonin, melatonin, epinephrine, norepinephrine. What are the inhibitors in this one? We have chlorgazoline, moclobemide, parglin, phenlenzine, and tranazipramine. And MAO-B, we have they are similar to that of the adults. Examples we have is dopamine, phenylethylamine, and then benzylamine. Inhibitors we have selegiline, rasagiline, phenelzine, and tranylcypromine. Sorry. So these are the few drugs which are different in phase 1 metabolisms compared to that of adults. And coming to phase 2 metabolisms, we have enzyme like N-methyl transferase that is similar to that of adults. Examples we have catecholamines and amines. Next, UGT, uridine diphosphate glucuronide transferase. They are basically lower than adults until 7 to 10 years of age. Examples we have paracetamol, morphine, and chloramphenicol. Next, we have N-acetyl transferase 2. They are lower until 1 to 4 years of age. Examples we have hydrolysine, isoniazid, and sulfonamide. Next, sulfate conjugation, they are similar to that of the adults. Examples is paracetamol and morphine. We just have to remember this phase 1 and phase 2 reactions. And then next, coming to drug excretion. So how excretion is different in adults and the children. Basically, excretion is an important step in the removal of drug from the body and any metabolites of the drug. It relies on effective renal and hepatic function that develop over time. So preterm neonates develop renal excretion pathways more slowly than term neonates. This is very much lower before 34 weeks of gestation. And then glomerular filtration rate, tubular secretion, and tubular reabsorption all are decreased in newborn. Tubular secretion basically depends upon the renal blood flow. Glomerular filtration rate of neonates is only 30 to 40% of adults, and by the end of 3 weeks, it reaches to 50 to 60%, and it reaches adult value by the age of 1 year. Tubular secretion gradually increases to adult value until the age of 6 to 12 months. This can decrease clearance of penicillins, aminoglycosides, and cephalosporins in early infancy. Tubular reabsorption gradually increases and reaches its maturation by around 3 years of age. And due to disproportional rate of development of glomerular filtration and tubular reabsorption during toddlerhood, excretion of some drugs exceed adult value. For an example, a relatively more glomerular filtration rate than the tubular reabsorption capacity increase renal clearance of imipenem, cilastin during first 3 years of age. So these are the different elimination half-lives of the drugs in adult and neonate. So if we are taking acetaminophen in neonate, it is 2.2 to 5 hours T-half. And whereas in adult, it is 0.9 to 2.2 hours. Diazepam is 25 to 100 T-half, 100 hours. And then in adults, it is 40 to 50. Digoxin you are taking, it is 60 to 70. Adults, it is 30 to 60. Phenobarbital, it affects differently in different age groups. Like from 0 to 5 days, it is 200. 5 to 15 days, it is 100. And 1 to 30 days, it is 50 in neonates. Whereas in adults, it is 64 to 140 hours. And then if you're taking phenytoin, it is also affecting differently in different days. Like 0 to 2 days, the T half is 80, whereas 3 to 14 days, it is 18, and 14 to 50 days, it is 6. In adults, the T half of the phenytoin is 12 to 18 hours. And salicylates in neonates, it is 4.5 to 11 hours, whereas in adult, it is 10 to 15 hours. Theophylline affect differently in neonates and in children. So in neonates, it is 13 to 26 hours, whereas in child, it is 3 to 4 hours. In adult, it is 5 to 10 hours. These are different elimination half-lives of various drugs. So coming to the pharmacodynamic changes, basically the apparent developmental differences in drug efficacy or incidence of adverse effect in children has been linked with pharmacokinetic differences only. Like for an example, the higher acid inhibition effects of lansoprazole in infants appears to be associated with reduced drug elimination and increased hepatotoxicity of valproic acid in young children, that was related to increased formation of hepatotoxic metabolites. So the existence of true age dependent differences in receptor sensitivity appears to be supported by data on few drugs only. So let's see what are the different age dependent adverse reactions. We'll see. Valproate hepatotoxicity increased in young children, and thalidomide causes phocomelia while the limb is forming. Gray baby syndrome, chloramphenicol in young children. Tetracyclines, the only stain, tetracycline, they leave a stain on the developing enamel of the teeth. These are few examples which come under the pharmacodynamic changes. So next, coming to the principles of drug prescribing in infants, principles of drug prescribing in infants and children. Pediatric prescribing is much more complicated than prescribing for adults, right? So because we have a different dosage forms, and then the dose is different from adult, and you have to calculate the proper dose based on weight, the body surface area, and all. So that is why the prescribing is a bit complicated in children rather than prescribing for adults. The specific and general aspects of pediatric patients, the limitations of commercially available dosage formulations, the varieties of administering medicines, the general inadequacy of clinical pharmacology training, and the dearth of information about drug usage in children. All these add to the difficulties facing the practitioner who treats infants and children. So for these reasons, practitioners should prescribe judiciously. They have to select carefully the safest dosage regimen available, and they have to educate the parents, patients, caregivers, and the staff about their choices and expected positive and negative effects of the particular drug. The practitioners should also have available and use written, electronic, as well as human sources of expert advice while advising the patient's parents or caregivers. And they should write all prescriptions legibly and carefully, document their therapeutic decisions and plans, and carefully monitor the patient's responses to therapy. And careful attention to the principles of clinical pharmacology can do much much to improve the efficacy of pediatric prescribing, and they decrease its cost and risk in pediatric population. Sorry. So next, coming to the pediatric dosage forms and adherence. Uh, the form in which yeah the form in which a drug is manufactured and the way in which the parent dispenses the drug to the children determine the actual dose administered. So many drugs prepared for children are in the form of elixirs or suspensions. So elixirs are nothing but alcoholic solutions in which the drug molecules are dissolved and evenly distributed. Whereas in suspensions, they contain undissolved particles of drug that must be distributed throughout the vehicle by shaking. So when you're giving these elixirs, basically when you're taking syrups, it will be like they will mention shake well before use, right? So that shake well before use, why it is there? Because so that the particles are evenly distributed throughout the bottles. What happens in elixirs, the particles are evenly distributed and need not shake the bottle before giving the drug. Whereas in suspensions, as there are undissolved particles, they have to be shaken. If shaking is not done properly in suspension, every time whenever the drug is given, there are high chances that the dose which you are giving first, I mean the upper part of the solution, it may contain low concentration of drug, whereas the last dose, it may contain the high concentration of the drug. What happens when the drug dose is low? There will be inefficacy of the medication. What happens when you're giving the high concentration of the drug? There will be toxicity. That is why shaking of the suspension is compulsory and mandatory in order to avoid inefficacy and the toxicity of the drug. So these are a few dosage forms which are given in children, elixirs and suspensions. And coming to adherence, adherence may be more difficult to achieve in pediatric practice because it involves not only parents' consciousness effort to follow the directions, but also such practical matters as measuring errors, spilling, or spitting out of the drugs are also involved. Like for an example, the measured volume of teaspoon can vary from 2.5 to 7.5 ml. What happens if the doctor is prescribing 5 ml, let's say? The spoon size what mother might have taken might be 7.8 ml. So she thinks that the 1 teaspoon is okay, it is 5 ml. I'll give it off 1 teaspoon. So what happens? There will be overdosing. In order to avoid these, the parent should obtain a calibrated medicine spoon or a syringe from the pharmacy, as these devices improve the accuracy of dose measurements and they simplify the administration of drugs to the children. Sorry. Practical and convenient dosage forms and dosing schedules should be chosen to the extent possible. Basically, what happens, let's say the particular drug has been prescribed to give sixth hourly. If sixth hourly, the parent has to give the drug, you have to tell whether it is mandatory, like if a child is sleeping during that 6 hours of time, it is time for giving the drug. So whether the mother should wake up the child or they can just leave it so that they can give after the child wakes up. All these care must be taken when we are prescribing and telling. So the easier it is to administer and take the medicine, the easier the dosing schedule is to follow. The more likely it is that adherence will be achieved. The parents can be told why it is important to continue giving the medicine for prescribed period even if the child seems to be cured. Whenever a drug dose does not achieve its therapeutic effect, the possibility of non-adherence should be considered. What happens sometimes, the parent might not have followed the prescribed pattern, or they might have given the less less dose, like that. All these non-adherence should be considered when there is no therapeutic effect of the drug is seen. Next, coming to the pediatric drug dosage. Because of differences in pharmacokinetic in infants and children, simple proportionate reduction in adult dosage may not be adequate to determine a safe and effective pediatric dosage. So the most reliable pediatric dose information is usually that is provided by the manufacturer in the package insert. You all might have seen, like if you buy a syrup, he will give a small information paper. So in that information paper, basically they will be mentioning the dose, and also if you take a bottle, the composition will be there. Like if you're taking a paracetamol syrup, let's say for an example, it with the paracetamol syrup has got different dosage forms, right? So one syrup will be 125 mg, one syrup will be 250 mg, one syrup will be 100 mg. So when you're calculating to give the dose for the child, you just have to see how much ml is containing how much mg. Like for the paracetamol only, if you're taking the P125 syrup, it will be having the 5 ml will be containing the 125 mg. So based on that, you have to calculate and give that the manufacturer given information. Sometimes what happens that information is not available for some products. So most of these drugs approved for use in children have recommended pediatric doses, generally stated as milligrams per kilogram or per pound. In absence of explicit pediatric dose recommendations, an approximation can be made by any of the several methods based on age, weight, or surface area. These rules are not precise and should not be used if the manufacturer is providing a pediatric dose. When pediatric doses are calculated, the pediatric dose should never exceed the adult dose. Like in this, the pediatric exceeding the adult dose, we can say if the child is obese, if you're calculating the basic adult dose is 100 mg, and you're calculating based on the child's weight, if the mg is coming around 150 mg, so that is not correct. So we have to consider that also, and the pediatric dose that should not exceed the adult dose. Like the current epidemic proportions of the childhood obesity calls for a careful look at pediatric drug dosages. Studies in adults indicate that dosing based on per kilogram body weight may constitute overdosing, because in obese subjects, drugs are distributed based on lean body weight. So we have to take all these considerations and then calculate the dose. Calculations of dosage based on age or weight are conservative and they tend to underestimate the required dose. The doses based on surface area are more likely to be adequate in such cases. We have two rules, like calculation based on age and calculation based on weight. So based on age, we have Young's rule. How is it calculated? The dose is equal to the adult dose into age, which is to be considered in years, divided by age in years plus 12. This is how you calculate using the Young's rule. Whereas Clark's rule, that is through weight, the dose is calculated based on weight. That is Clark's rule. So dose is equal to adult dose into the weight in kgs by 70, or the dose is equal to adult dose into weight in pounds divided by 140. Okay, by using these two methods, we can calculate the dose based on weight, and by using the Young's rule, we can calculate the dose based on age. Next, we have the determination of drug dosage from the surface area approximately. Like if you're taking the weight to be the baby's weight to be 3 kgs, basically that's a newborn. So surface area in meter square would be 0.2. The percentage of adult dose will be 12. So if 6 kgs, then we have 3 months, 0.3 and 18. 10 kgs, we have approximate age will be 1 year. Surface area will be 0.45, and the percentage of adult dose is 28%. In if you are taking 20 kgs, that would be 5.5 years, 0.8 meter square, and then adult dose is 48. 30 kgs, 9 years, surface area 1, and percentage of adult dosage 60%. If you're taking 50 kgs, then the approximate age would be 14 years. Then the surface area will be 1.5, and percentage is 90%. And when the adult is like around 60 to 70 kgs, it is obviously adult age. The surface area would be 1.7 to 1.76, and the percentage of adult dose is almost 1 or 2 to 1 or 3. So these are all the considerations which we have to think about. And I would like to so these are all the considerations you have to think about. And these are the different drug dosage from the surface area. And I would like to conclude my session like for this. So what we have to remember is that the pharmacokinetic properties in pediatric age group differ from that of the adult. Okay. And the pediatric age, in pediatric age group, newborn, neonate, infant, children, they all differ in pharmacokinetic properties. The pharmacokinetic properties changes due to change in physiology. All these physiological changes, they gradually take child to adult phase. So the proper knowledge has to be maintained for different pharmacokinetics in different pediatric population. That is very much essential. And we have to explore different pharmacodynamic changes. We have to follow the prescribing principles, and what are the different dosage forms and adherence we have to follow while giving to the children. So with this, I would like to conclude my session. Thank you. Any doubts, you can feel free to ask. Thank you.